Hello friends, welcome to my YouTube channel. Today we are going to discuss about anticholinergic drugs. This is an important concept in ANS pharmacology. Conventionally, the term anticholinergic drugs is restricted to those which block actions of ACH on autonomic effectors and in the CNS exerted through muscarinic receptors. Though nicotinic receptor antagonists also block certain actions of ACH, they are generally referred to as ganglion blockers and neuromuscular blockers. All anticholinergics are competitive antagonists. Pharmacological actions: atropine as a prototype, it blocks all types of muscarinic receptors. 1. CNS: atropine has an overall CNS stimulant action. However, these effects are not appreciable at low doses, which produce only peripheral effects because of restricted entry into the brain. Hyoscine produces central effects, depressant, even at low doses. Atropine stimulates many medullary centers, vagal, respiratory, vasomotor. It depresses vestibular excitation and has anti-motion sickness property. The site of this action is not clear. Probably there is a cholinergic link in the vestibular pathway, or it may be exerted at the cortical level. By blocking the relative cholinergic overactivity in basal ganglia, it suppresses tremor and rigidity of Parkinsonism. High doses cause cortical excitation, restlessness, disorientation, hallucinations and delirium, followed by respiratory depression and coma 2. CVS. Heart: the most prominent effect of atropine is tachycardia. It is due to blockade of M2 receptors on the SAW node, through which vagal tone decreases hour. On I. M. S. C. Injection transient initial bradycardia often occurs. Earlier believed to be due to stimulation of vagal center, it is now thought to be caused by blockade of muscarinic autoreceptors M1 on vagal nerve endings, thereby augmenting ACH release. This is suggested by the finding that selective M1 antagonist benztropine is equipotent to atropine in causing bradycardia. Moreover, atropine substitutes which do not cross blood-brain barrier also produce initial bradycardia. Atropine abbreviates refractory period of AV node and facilitates AV conduction, especially if it has been depressed by high vagal tone. PR interval is shortened. BP: since cholinergic impulses are not involved in the maintenance of vascular tone, atropine does not have any consistent or marked effect on BP. Tachycardia and vasomotor center stimulation tend to raise BP, while histamine release and direct vasodilator action, at high doses, tend to lower BP. 3. Eye: topical instillation of atropine causes mydriasis, abolition of light reflex and cycloplegia lasting 7 to 10 days. This results in photophobia and blurring of near vision. The ciliary muscles recover somewhat earlier than sphincter pupillae. The intraocular tension tends to rise, especially in narrow-angle glaucoma. 4. Smooth muscles. All visceral smooth muscles that receive parasympathetic motor innervation are relaxed by atropine, M3 blockade. Tone and amplitude of contractions of stomach and intestine are reduced. The passage of chyme is slowed, constipation may occur, spasm may be relieved. However, peristalsis is only incompletely suppressed because it is primarily regulated by local reflexes in the enteric plexus, and other neurotransmitters, 5-HT, enkephalin, etc., are involved. Enhanced motility due to injected cholinergic drugs is more completely antagonized than that due to vagal stimulation, because intramural neurons which are activated by vagus utilize a number of non-cholinergic transmitters as well. Atropine causes bronchodilation and reduces CES airway resistance, especially in COPD and asthma patients. Inflammatory mediators like section 2 histamine, PGs, leukotrienes and kinins which participate in asthma increase vagal activity in addition to their direct stimulant action on bronchial muscle and glands. Atropine has relaxant action on ureter and urinary bladder. Urinary retention can occur in older males with prostatic hypertrophy. However, this relaxant action can be beneficial for increasing bladder capacity and controlling detrusor hyperreflexia in neurogenic bladder, enuresis. Relaxation of biliary tract is less marked and effect on uterus is minimal. 5. Glands atropine markedly decreases sweat, salivary, tracheobronchial and lacrimal secretion, M3 blockade. Skin and eyes become dry, talking and swallowing may be difficult. Atropine decreases secretion of acid, pepsin and mucus in the stomach, but the primary action is on volume of secretion so that pH of gastric contents may not be elevated unless diluted by food. Since bicarbonate secretion is also reduced, rise in pH of fasting gastric juice is only modest. Relatively higher doses are needed and atropine is less efficacious than H2 blockers in reducing acid secretion. Intestinal and pancreatic secretions are not significantly reduced. Bile production is not under cholinergic control, so not affected. 6. Body temperature. Rise in body temperature occurs at higher doses. It is due to both inhibition of sweating as well as stimulation of temperature-regulating center in the hypothalamus. Children are highly susceptible to atropine fever. 7. Local anesthetic. Atropine has a mild anesthetic action on the cornea. Atropine has been found to enhance ACH, also Na, release from certain postganglionic parasympathetic and sympathetic nerve endings, and thus produce paradoxical responses. This is due to blockade of release inhibitory muscarinic autoreceptors present on these nerve terminal. Classification of anticholinergic drugs include these: natural, semi-synthetic and synthetic drugs. Its classification has been memorized by the trick in another video. You can watch that by pressing the I button. Uses of each individual drugs. Quaternary compounds. These drugs have certain common features: incomplete oral absorption, 10 to 30%, poor penetration in brain and eye. Central and ocular effects are not seen after parenteral, oral administration. 1. Hyoscine butyl bromide 20 to 40 mg oral, I. M. S. C. I. V. Less potent and longer acting than atropine. Used for esophageal and gastrointestinal spastic conditions. 2. Atropine methonitrate 2.5 to 10 mg oral, I. M. For abdominal colics and hyperacidity. 3. Ipratropium bromide 40 to 80 micrograms by inhalation. It acts selectively on bronchial muscle without altering volume or consistency of respiratory secretions. Another desirable feature is that in contrast to atropine, it does not depress mucociliary clearance by bronchial epithelium. It has a gradual onset and late peak, at 40 to 60 minutes, of bronchodilator effect in comparison to inhaled sympathomimetics. Thus, it is more suitable for regular prophylactic use rather than for rapid symptomatic relief during an attack. Action lasts 4 to 6 hours. It acts on receptors located mainly in the larger central airways. Contrast sympathomimetics whose primary site of action is peripheral bronchioles. The parasympathetic tone is the major reversible factor in chronic obstructive pulmonary disease, COPD. Therefore, ipratropium is more effective in COPD than in bronchial asthma. Transient local side effects like dryness of mouth, scratching sensation in trachea, cough, bad taste and nervousness are reported in 20 to 30% patients. but systemic effects are rare because of poor absorption from the lungs and g. I.T. major fraction of any inhaled drug is swallowed. 4. Tiotropium bromide, a newer congener of ipratropium bromide which binds very tightly to bronchial M1, M3 muscarinic receptors, producing long-lasting bronchodilation. Binding to M2 receptors is less tight, conferring relative M1, M3 selectivity, less likely to enhance ACH release from vagal nerve endings in lungs due to M2 receptor blockade. Like ipratropium, it is not absorbed from respiratory and G.I. mucosa and has exhibited high bronchial selectivity of action. 5. Pro-banthine 15 to 30 mg oral. It was a popular anticholinergic drug used for peptic ulcer and gastritis. It has some ganglion blocking activity as well and is claimed to reduce gastric secretion at doses which produce only mild side effects. Gastric emptying is delayed and action lasts for 6 to 8 hours. Use has declined due to availability of H2 blockers and proton pump inhibitors. 6. Oxyphenonium. 5 to 10 mg, children 3 to 5 mg, oral. Similar to pro-banthine, recommended for peptic ulcer and gastrointestinal hypermotility. 7. Clidinium 2.5 to 5 mg oral. This antisecretory antispasmodic has been used in combination with benzodiazepines for nervous dyspepsia, gastritis, irritable bowel syndrome, IBS, colic, peptic ulcer, etc. 8. Simetropium bromide, a quaternary ammonium anticholinergic antispasmodic drug, especially promoted for IBS. About 50% patients of IBS get 30 to 70% relief in abdominal pain and loose motion. Dryness of mouth is the commonest side effect. 9. Isopropamide 5 mg oral. Indicated in hyperacidity, nervous dyspepsia, IBS and other gastrointestinal problems, especially when associated with emotional, mental disorders. 10. Glycopyrrolate 0.2 to 0.4 mg I.M. 4 to 5 micrograms, kilogram. Potent and rapidly acting anti-muscarinic lacking central effects. It is almost exclusively used for pre-anesthetic medication and during anesthesia. Tertiary amines 1. Dicylomine 20 mg oral, I.M. Children 5 to 10 mg. Has direct smooth muscle relaxant action in addition to weak and somewhat M1 selective anticholinergic action. It exerts antispasmodic action at doses which produce few atropinic side effects. However, infants have exhibited atropinic toxicity symptoms and it is not recommended below 6 months of age. It also has antiemetic property. Has been used in morning sickness and motion sickness. Dysmenorrhea and irritable bowel are other indications. 2. Volethimate. The primary indication of this anticholinergic smooth muscle relaxant is to hasten dilatation of cervix when the same is delayed during labor, and as visceral antispasmodic, for urinary, biliary, intestinal colic. Dose 8 mg IV or 10 mg orally. 3. Parasympatholytic. It selectively blocks M1 muscarinic receptors and inhibits gastric secretion without producing typical atropinic side effects. These are due to blockade of M2 and M3 receptors. The more likely site of action of benztropine in stomach is intramural plexuses and ganglionic cells rather than the parietal cells themselves. It was indicated in peptic ulcer, but has been overshadowed by H2 blockers and proton pump inhibitors. Vasocoselective anticholinergics 1. Oxybutynin. This anti-muscarinic has high affinity for receptors in urinary bladder and salivary glands, along with additional smooth muscle relaxant and local anesthetic properties. It is relatively selective for M3 and M1 subtypes with less action on the M2 subtype. Because of vasicoselective action, it is used for detrue sore instability resulting in urinary frequency and urge incontinence. Beneficial effects have been demonstrated in post-prostatectomy vesical spasm, neurogenic bladder, spina bifida and nocturnal enuresis. Anticholinergic side effects are common after oral dosing, but intravesical instillation increases bladder capacity with few side effects. Oxybutynin is metabolized by CYP3A4. Its dose should be reduced in patients being treated with inhibitors of this isoenzyme. Dose: 5 mg BD, TDS oral. Children above 5 years 2.5 mg BD. 2. Tolterodine. This relatively M3 selective muscarinic antagonist has preferential action on urinary bladder, less likely to cause dryness of mouth and other anticholinergic side effects. It is indicated in overactive bladder with urinary frequency and urgency. Since it is metabolized by CYP3A4, dose should be halved in patients receiving CYP3A4 inhibitors, erythromycin, ketoconazole, etc. 3. Flavoxate. It has properties similar to oxybutynin and is indicated in urinary frequency, urgency and dysuria associated with lower urinary tract infection. 4. Darifenacin. Another relatively M3 selective antimuscarinic with preferential action on bladder muscles. Indicated in urinary incontinence, urgency and frequency. Dose: 7.5 to 15 mg OD5. Solifenacin. It is similar to darifenacin. No clinically significant difference between the two has been observed in clinical trials on patients with overactive bladder. Dose: 5 to 10 mg OD6. Drotaverine. It is a non-anticholinergic smooth muscle antispasmodic which acts by inhibiting phosphodiesterase 4, PDE4, selective for smooth muscle. Elevation of intracellular CAMP, CGMP attends smooth muscle relaxation. Changes in membrane ionic fluxes and membrane potential have also been shown. It has been used orally as well as parenterally in intestinal, biliary and renal colics, IBS, uterine spasms, etc. Without anticholinergic side effects. Adverse effects reported are headache, dizziness, constipation and flushing. Fall in BP can occur on I versus injection. Dose: 40 to 80 mg TDS. Mydriatics 1. Atropine is a potent mydriatic, but its slow and long-lasting action is undesirable for refraction testing. Though the pupil dilates in 30 to 40 minutes, cycloplegia takes 1 to 3 hours, and the subject is visually handicapped for about a week. Atropine substitutes attempt to overcome these difficulties. However, atropine itself is used in iridocyclitis, keratitis, etc. too. Homatropine. It is 10 times less potent than atropine. Instilled in the eye, it acts in 45 to 60 minutes. Mydriasis lasts 1 to 3 days while accommodation recovers in 1 to 2 days. 3. Cyclopentolate. It is potent and rapidly acting. Mydriasis and cycloplegia occur in 30 to 60 minutes and last about a day. It is preferred for cycloplegic refraction, but children may show transient behavioral abnormalities due to absorption of the drug after passage into the nasolacrimal duct. It is also used in iritis and uveitis. 4. Tropicamide. It has the quickest, 20 to 40 minutes, and briefest, 3 to 6 hours, action, but is a relatively unreliable cycloplegic. However, it is satisfactory for refraction testing in adults and as a short-acting mydriatic for funduscopy. The mydriatic action can be augmented by combin-ing with phenylephrine. As anti-secretory drugs, pre-anesthetic medication when irritant general anesthetics, ether, were used. Prior administration of anticholinergics, atropine, hyoscine, glycopyrrolate, was imperative to check increased salivary and tracheobronchial secretions. Pulmonary embolism. Atropine benefits by reducing pulmonary secretions evoked reflexly by embolism. To check excessive sweating or salivation, e.g. in Parkinsonism. Use of anticholinergics in peptic ulcer is obsolete. As antispasmodic drugs 1. Intestinal and renal colic, abdominal cramps. Symptomatic relief is afforded if there is no mechanical obstruction. However, in renal colic parenteral opioids and NSAIDs provide greater pain relief than atropine. Atropine is less effective in biliary colic and is not able to completely counteract biliary spasm due to opiates. Nitrates are more effective. 2. Nervous, functional and drug-induced DRRHOEA may be controlled to some extent, but anticholinergics are not useful in infective diarrhea. 3. Spastic constipation, IBS. Modest symptomatic relief in abdominal discomfort and irregular bowel evacuation may be obtained. Amitriptyline and other TCAs may befit non-responders. 4. Pylorospasm, gastric hypermotility, gastritis, nervous dyspepsia may be partially suppressed. 5. To relieve urinary frequency and urgency, ENU-resis in children. Vasocoselective M3 antimuscarinics like oxybutynin, tolterodine, fluvoxate and darifenacin have demonstrated good efficacy. They may also increase bladder capacity, but dry mouth and other anticholinergic effects are dose-limiting. 6. Dysmenorrhea. Anticholinergics are not very effective. NSAIDs are superior. 5. As cardiac vagolytic, atropine is useful in counteracting sinus bradycardia and partial heart block in selected patients where increased vagal tone is responsible, e.g. in some cases of myocardial infarction and in digitalis toxicity. However, cardiac arrhythmias or ischemia may be precipitated in some cases. 6. Bronchial asthma, asthmatic bronchitis, COPD-7. To antagonize muscarinic effects of drugs and poisons, atropine is the specific antidote for anti-Che and early mushroom poisoning. Atropine or glycopyrrolate is also given to block muscarinic actions of neostigmine used for myasthenia gravis, decurization or cobra envenomation. Interactions. 1. Absorption of most drugs is slowed because atropine delays gastric emptying. This results in slower absorption and greater peripheral degradation of levodopa. Less of it reaches the brain. This does not occur when a peripheral decarboxylase inhibitor is combined. On the other hand, extent of digoxin and tetracycline absorption may be increased due to longer transit time in the GI. 2. Antacids interfere with absorption of anticholinergics. 3. Antihistaminics, tricyclic antidepressants, phenothiazines, disopyramide, pethidine have anticholinergic property. Additive side effects occur with Atropinic drugs. 4. MAO inhibitors interfere with metabolism of anticholinergic antiparkinsonian drugs. Delirium may occur. Toxicity, diagnosis, methacholine 5 mg or neostigmine 1 mg S.C. fails to induce typical muscarinic effects. Treatment. If the poison has been ingested, gastric lavage should be done with tannic acid. Potassium permanganate is ineffective in oxidizing atropine. The patient should be kept in a dark, quiet room. Cold sponging or ice bags are applied to reduce body temperature. Physostigmine 1 to 3 mg s.c. or I. versus antagonizes both central and peripheral effects, but has been found to produce hypotension and arrhythmias in some cases. Thank you for watching. Subscribe for more useful content. Goodbye till then.